Welcome to our presentation today on understanding the condition food avoidance and sensitivity trap. We're very excited for this presentation and to hear from our speakers. My name's Eloise. I'll be your host, and I'm one of the clinical specialists at Mindset Health. And a huge thank you to Mindset Health for running this webinar series, and again to our speakers for bringing this session to life. Without further ado, I'd love to introduce our speakers. First of all, we have Wendy. So Wendy Bussey is a registered dietitian and a nationally recognized food sensitivity expert. She's the founder and director of Rebuild Food Tolerance, which helps food sensitive clients expand their diet and enjoy food freedom. We're very lucky to be hearing from you today. Thank you, Wendy. And our second speaker, who is just having a few technical difficulties, is Joanna Baker. I'd like to still introduce her while she's jumping back on. So Joanna is an accredited practicing dietitian and registered nurse who loves food. Her passion for digestive health stems from a lifelong battle with IBS, which has taught her both how hard it is to live with unpredictable gut symptoms and how life-changing it can be when food sensitivities are well managed. At Everyday Nutrition, she works exclusively with people who have digestive issues to help them resolve their issues and make peace with food. Great timing, Jo. Thanks for jumping back on.
Just crashed on me.
Don't stress. You're here perfectly on time. So what we're going to do today, we'll pass to Jo first. If you wouldn't mind sharing your slides, Jo, we'll jump back into it. Yep. Wendy will follow shortly after, and I will hand it over to you. Thank you so much.
Excellent. Thank you so much for that lovely introduction, Eloise. I'm feeling a little bit flustered now because my computer suddenly crashed and then I had to open it again. Anyway, a couple of deep breaths. Today we're talking about understanding the condition food avoidance and sensitivity trap, and we're going to include some dietetic strategies to enhance patient care. So what we're going to cover today, I'm going to start out by talking about what IBS is, how it's diagnosed, what the popular treatment options are for IBS, and the gut-brain axis. And then I'm going to hand over to Wendy, who's going to talk about the conditioned food avoidance and sensitivity trap. So to start off, irritable bowel syndrome, or IBS, it's a type of chronic pain that affects the gut and digestion. And what I mean by this is that it is an ongoing pain that doesn't have an identifiable cause. So it's actually considered a disorder of the gut-brain axis, and it affects around sort of 10 to 15% of the population. Now, although it doesn't damage the body in any way, it doesn't shorten lifespan in any way, the symptoms can range from mildly annoying to quite severe and debilitating. And I'm sure if some of you have worked with people with IBS, you'll have a good understanding of just how debilitating it can be. What that means in terms of our goals of treatment, there's nothing actually to heal or to fix, but our goal is to manage the symptoms and improve a person's quality of life. When it comes to doing this, diet, lifestyle, and stress are the sorts of things that are often identified as catalysts for worsening symptoms. So when we're looking at our diagnosis, the very first thing we want to do is start by excluding medical conditions that can have similar symptoms. So things like celiac disease, inflammatory bowel diseases, and certain cancers, they can all affect digestive symptoms as well. So we want to make sure that the symptoms our client is presenting with aren't caused by any of these things. We also want to investigate any red flag symptoms. So things like unintended weight loss, family history, rectal bleeding, unexplained iron deficiency, anemia, nocturnal diarrhea, and age of onset over 50 years. Now, if somebody has any of these symptoms, it doesn't necessarily mean that they do not have IBS, but it means that we need to do further investigation to exclude any other things before we can confirm that. If all of the testing comes back clear and we can't find a reason for their symptoms, we then use the Rome 4 criteria to diagnose them with IBS. And what that means is that they must have recurrent abdominal pain, on average at least 1 day a week in the last 3 months, although we like symptoms to have started more than 6 months ago. And that pain has to be related to bowel movements, a change in frequency, or a change in stool form. So 2 out of 3 of that criteria. if they fit that criteria, they can be diagnosed with IBS. Now, in my experience, a lot of medical providers are not that great at diagnosing IBS, and they might not necessarily give somebody an IBS diagnosis, or they might say, oh, you might have a bit of IBS, or yes, you have IBS, or they might say, I can't find anything wrong with you, go and see a dietitian. As a dietitian, I actually don't really care if somebody has an IBS diagnosis or not. If we know that their symptoms are not caused by a medical condition, and we know that then I'm going to treat them as IBS, regardless of whether they're given that IBS diagnosis or not. In terms of the types of tests that you might see people having done, celiac disease is one that's probably really important. The symptoms can present identical to IBS. So that celiac disease test, it's a blood test for screening. If the blood test comes back positive, then the next step is to have a gastroscopy and take a biopsy from the small bowel to check for that bowel damage that's classic of celiac disease. What's really important to check here is that your patients had this test, but also they weren't gluten-free leading up to having this test. So the gluten must be in the diet regularly, because we're looking for antibodies or damage that occurs when somebody with celiac disease eats gluten. They also might have had stool tests, things like fecal calprotectin or parasites, things like that. If they've got any red flag symptoms aged over 50 years, then the recommendation would be normally to have top and tail scopes and biopsies. They may have had an abdominal x-ray to assess for stool accumulation. This is probably the test I see least often, and the most common thing for me to send people back to their doctor for, because I find I used to think that I saw a little bit of fecal loading, but as time goes on, I'm actually seeing more and more and more of it. And I would say the most common reason I see these days for bloating is fecal loading. We also have national screening in line with the bowel cancer screening program. I'm not sure what they're doing in Canada and the US in regards to this, but here in Australia, on your 50th birthday, you get sent a little package in the mail to do your fecal occult blood test, and you get resent that every 2 years. So we want to make sure that somebody has been following those sort of national screening programs. And a medication review can always be helpful as well, because we do see situations, particularly as people get older or people have chronic diseases with this polypharmacy, where they may have one medication to treat one thing and then they get a side effect of that, so they have another medication to treat the side effect, and then they're just sort of adding medications on top of each other. And medications all have side effects, and gut symptoms are fairly common as well. So a bit of a medication review can often be quite helpful there. When we're coming to IBS, IBS is multifactorial. We don't have one specific cause, but we know that there are lots of things that do affect IBS symptoms. So we know the gut-brain axis plays a role. In some people, the pelvic muscle function can play a big role. We have gut irritants like fatty foods, spicy foods. High fiber foods can be irritating, caffeine. Our eating behaviors, so eating too fast, having big gaps between meals, or eating too much. Anybody who eats a large meal is going to be bloated and not chewing your food properly. Medications, as I just said. Hormones absolutely play a role. I'm seeing more and more women presenting to me in their mid-40s with worsening IBS symptoms that can often be related to perimenopausal symptoms as well, and it can be easily misdiagnosed as IBS. And of course, we've got our food sensitivity, which is what a lot of people tend to start to look at when they're researching and looking for answers for their IBS. What that means in terms of treatment is that people who are looking at a multimodal, or I talk about having an IBS toolbox, where you've got strategies that affect your diet and your eating behaviors. We've got medications and supplements, and then lifestyle and psychological methods. And I find people who use a range of strategies that cover all of these areas tend to be the ones who get best results. So when we're looking at our recommendations for treating IBS, we've got our NICE guidelines. The first line recommendation is things like general nutrition advice, meal size and timing, things like caffeine, exercise, stress, fiber, gut irritants, and then things like our artificial sweeteners like sorbitol, and to think about resistant starch. If that's not successful, their second line recommendation is to refer onto a dietitian to consider elimination diets, and they specifically mention the low FODMAP diet at that point. And they also talk about psychological interventions, probiotics, and further investigations at that point as well. We have the Gastroenterological Society of Australia. Their recommendations are to consider gut irritants, fibre, gassy foods, artificial sweeteners, and lifestyle factors. The American College of Gastroenterology is fairly similar. They specifically talk about the low FODMAP diet, they talk about fibre, and they talk about medications, while our PEND guidelines, again, fibre, medications, psychological therapies, and the low FODMAP diet. When we're looking at people who do live with IBS, these people are looking for answers, particularly when their symptoms are fairly debilitating, and particularly when they're getting their symptoms every day. Every time they go to the toilet, they're reminded that their gut is playing up. Most of them will have bloating throughout the day as well, are feeling uncomfortable. They come home from work and they're taking off their jeans and putting on their stretchy pants. So they're looking for answers because it is affecting their lives day in and day out. Many of them have been to doctors and have been not really given a lot of answers, or some people may have been told that it's all in your head. Some people may have been told to change their diet. We know that when it comes to diet, the low FODMAP diet is becoming increasingly popular. It's really well known these days. I'm probably fairly biased in terms of the people that I see, but I feel like everybody who's ever had a stomachache has been either told to do a FODMAP diet or has done a FODMAP diet. And we know that this is effective in around 75% of people with IBS. Depending on the research you look at, it may be anywhere from 50 to 80% effective. We know that up to 90% of people with IBS say that the food that they eat makes a difference to their symptoms. And there's also research showing that around 95% of doctors suggest dietary changes as a primary way to manage IBS symptoms. I'm certainly also seeing it a lot on social media as well, where doctors are just jumping straight and going straight to recommending a low FODMAP diet. People are, like I said, they're looking for answers. They're joining Facebook groups, and a lot of them are coming into the Facebook groups saying, my doctor recommended I do a low FODMAP diet for my IBS. And they're doing this, they're skipping the dietitian step and just recommending, giving people a single page food list, telling them to Google. Some may tell them to download the Monash app, but they're not referring to a dietitian to do this. We also know that Google search, if you jump on a Google search and search for IBS treatments, you're going to be given things like food and the low FODMAP diet, stress and medication options. And we also know from the research that when it does come to dietary intervention, so we know FODMAP helps around 75% of people with IBS, and we know that other medical treatments, things like medications, may only be around sort of 30 to 40% effective for IBS. So diet is significantly more effective. What that means when we're doing a diet, we're looking at something like the low FODMAP diet, for example, is an elimination diet to see if there's a reduction of symptoms. This is followed by food challenges to identify which foods trigger symptoms, and then we're wanting to liberalize their diet as much as possible while keeping their symptoms under control. So I always think we have food restriction on one hand to manage symptoms, and we have quality of life on the other hand, and quality of life in the middle, but restricting food affects quality of life, having symptoms affects quality of life, and what we're trying to find is a balance between the two that's going to give the person the best outcome. And of course, the most liberal diet possible is the best diet for anybody. One of the questions that I ask with this elimination and reintroduction process is, does this process actually amplify the perception that food is to blame for the symptoms? And I always question whether food is actually to blame for the symptoms, or is it just a catalyst that has an impact on symptoms. So, and the reason I say this is that when we start looking at things like FODMAPs and the gut-brain axis, we know that FODMAPs are types of carbohydrates that are poorly digested. They continue through the stomach, through the small intestine, into the large intestine before finally leaving the body when you open your bowels. As they're going through the intestines, they have an osmotic effect, which means they attract water into the digestive tract, and they're also fermented by the healthy bacteria that live in the large intestine, and this creates gas as a side effect. And where I sort of start to question whether food is actually the trigger for whether you can consider FODMAPs a trigger for IBS symptoms, is that the thing is, some FODMAPs, the onion, the garlic, the wheat, and the legumes, are actually FODMAPs for everybody across the board. In everybody who eats these, they are poorly digested, and everybody, they will create gas in the intestines, and they will stretch the walls of the intestines, and they will push on the nerve endings around those intestines. Now, whether this is a problem or not really comes down to the sensitivity of the nerves around the intestines. So if you've got somebody with low visceral sensitivity that's stretching of the walls and pushing on the nerves ignore that and they don't respond to that. So the person might walk around saying, I'm farting a lot today, isn't that funny? Or somebody else who has higher visceral sensitivity, where those nerves are more sensitive, they might start getting pain and discomfort and bloating as a result of that stretching of the walls of the intestine. So it really comes down to the enteric nervous system and how it responds to that increase in water as the underlying cause for why FODMAPs are causing symptoms in some people, but not in other people. And this was shown from the study by Wu et al. In 2022. It was only a small study, but they had 13 people with medically diagnosed IBS, and they had 13 healthy controls. And what they did, they inserted nasogastric tubes, and they gave each person an infusion of saline on one day, fructans on another day, and glucose on another day. And then during those infusions, or in the hours after those infusions, they measured symptom severity and emotional state using validated scales. In addition to that, they also performed brain and abdominal MRIs. What they found is that fructans increased gas and motility equally in people with IBS and in the healthy control. So both of them had an increase in gas and motility. But the people with IBS reported more pain, bloating, cramps, and flatulence in response to fructans than they did with the saline and the glucose, and also than the healthy controls. So we can see over on this graph over here, so the red solid line there is the fructans in the healthy controls, and we can see that bloating was elevated. We can see the table here with cramps was significantly elevated in those people, also the flatulence and the pain. What they also found from the MRI is that the pain centers in the brain were activated in people with IBS with the fructans, but those pain centers were not activated with the glucose, the saline, or in the healthy controls. So I thought I'm just going to jump back and do sort of a bit of a pain pathways anatomy and physiology 101. We have our 5 senses: sight, touch, taste, sound, all of those. What their job is actually to collect information from our outside world. They send this information to our brain for interpretation. When the information arrives in the brain considers past experience, current situations, and future expectations. And if it decides that there is danger, the brain will then send pain as an alarm bell to get your attention, to get you to remove yourself from danger. So in a nutshell, if you were to put your finger on a hot element, your finger would collect the heat sensation. It would send that to the brain. The brain would say, hey, I recognize that. If I leave my finger there, it's going to get burnt. So it sends pain back to your finger to get you to move your finger away from the element. And in that way, your brain, the pain is protecting you. So pain is a protective mechanism in that sense. When it comes to IBS and the gut-brain axis, we also have our enteric nervous system, which are the nervous system all in and around our intestines and internal organs. And one of their jobs is to collect information about our inside world, so about our digestion and what's going on down there, and communicate that information with the brain up the vagus nerve or the gut-brain axis. In IBS, it's thought that people with IBS, their enteric nervous system and those nerves in that gut, these are oversensitive. They are over-collecting information, and they are over-communicating that information with the brain. And some of that information is getting scrambled as it travels up and down the gut-brain axis. So what we have is the brain is getting flooded with information. Some of that information is incorrect, and that makes the brain start to think that there's probably something going wrong down there. So it starts sending down pain messages back into the gut to get your attention, to get what it thinks or what it's perceiving as a danger signal going on. The thing about our nervous system is that it's not hardwired like the electrics in a house. Our nervous system, it does grow and learn and evolve. And we end up with this situation where the nerves in the gut are over collecting information about every little thing that's going on with digestion and over communicating with the brain. The brain is sending back pain messages, and the nerves are thinking, oh, well, the brain is concerned about this as well. So we better keep collecting information and keep communicating it to the brain and keep everybody in the loop. And we end up with this sort of positive reinforcement cycle going between the gut and the brain that is misguided. We also have the situation where having symptoms is stressful, and we also know that we also have sort of chronic life stresses as well. And stress, whether it be acute or chronic, it does increase the sensitivity of the gut nerves, or it increases the sensitivity of all the nerves in your body, to make them more alert to a potential danger. So you end up in this situation where, are you stressed because you've got symptoms, or do you have symptoms because you're stressed, and you're sort of, again, stuck in that cycle? When you're reminded of that every day, of course, we have to consider that what you focus on, you also amplify as well. So if you are looking for symptoms, you are going to start seeing symptoms, and you're going to start increasing that sensitivity as well. So I'm going to hand over to Wendy now.
All right, I'm going to get my slides going here. So thank you, Joe, so much for giving that really clear explanation of the gut-brain axis. And I wanted to continue with the concept that pain and symptoms can become a learned response. And another name for a learned response is conditioned response. So I'm sure you've all heard of Pavlov's dog. Pavlov was studying digestive enzymes about 130 years ago, and he wanted to collect saliva from dogs. So he would ring a bell and then feed the dogs. And after a while, he noticed the dogs started to salivate as soon as they heard the bell. So the neutral cue became associated with the meaningful cue, and then the bell produced the same physiological reaction as the food. Fear conditioning is a subset of Pavlovian conditioning. In this case, a neutral cue like food can become associated with a meaningful cue like unpleasant sensations, and then the food can elicit these sensations, leading to a vicious cycle of food avoidance and worsening sensitivity. To explain this vicious cycle, I've developed the conditioned food avoidance and sensitivity trap, or CFAST. The client's struggles often start with unpleasant sensations, and this uncertainty can lead to body and food mistrust, in other words, fear. So then food and physical sensations become danger cues, which leads to conditioned avoidance. And if those danger cues become firmly entrenched, the client's hypervigilant nervous system may react to the food, and then that leads to additional unpleasant sensations. So let's further explore these definitions. So I define conditioned food avoidance as diet restriction driven by food symptom associations. These associations can be accurate. If they are, this leads to a beneficial restriction. So in other words, that would be a biological in origin food reaction, or they can be inaccurate and, excuse me, please, which leads to excess restriction. And I define conditioned food sensitivity as food reactions driven by inaccurate food symptom associations. So in other words, fear and negative expectations create or intensify the individual's unpleasant sensations. So a few minutes ago, we discussed how food can become associated with symptoms, and then eating or even thinking about the food can reproduce the physiological mechanisms to recreate those sensations. And this, as you know, is an example of the nocebo response. So the detailed CFAS, so we just went over the simplified CFAS, but the detailed CFAS provides a more comprehensive understanding of this vicious cycle. And I'm going to go through it with a case study. This information is available in Module 2 of my Rebuild Food Tolerance course, which is open to the public, so you don't need to take notes. So Janet had indigestion, bloating, gas, and occasional diarrhea. Her doctor ran several tests, but everything came back in the normal range, so she didn't get an explanation for why she was feeling so poorly. So this uncertainty led to body mistrust, and the first consequence of body mistrust is symptom hypervigilance. And when we're hypervigilant, our nervous system is on alert, watching for dangers. Just like Joe had said, we whatever we're concerned about, we pay more attention to. So she paid close attention to the sensations in her digestive system, and her hypervigilant nervous system then interpreted those sensations as problematic and a potential symptom flare, which unfortunately just intensified the sensation. So this mini cycle kept going around and around until her symptoms got worse. The second consequence of body mistrust is being drawn into research. She wanted to understand why she was feeling so poorly. So she read several websites and joined a Facebook group for irritable bowel syndrome. Unfortunately, she found misleading, sensational theories about the dangers of food, especially carrots. And I'm just using carrots as an example food in this case study. If she'd read these theories before her health concerns started, she would know that they were exaggerated. But her hypervigilant mind was searching for answers and grabbed onto the sensational theories. So the messages intensified her body mistrust, which worsened her symptom hypervigilance and ended up leading into this first mini cycle. So in addition, she started down the slippery slope of food mistrust, which drove further research. And so now she was also stuck in the second mini cycle. Experiences such as reading or hearing about the dangers of food creates a link between food and unpleasant sensations, and it leads to food symptom associations. In Janet's case, her nervous system created a carrot digestive distress association, which was reinforced each time she thought or talked about it, as she frequently did in her Facebook group. So she got trapped in the third mini cycle. Carrot became a danger cue. So she tried to control this perceived threat by eliminating it. And this food rule led to a condition avoidance. So once again, I define condition avoidance as food restriction that is driven by food symptom associations. Unfortunately, avoidance reinforces and amplifies a danger cue. So at first, she eliminated obvious sources of carrot, but after a while, her food rules became stricter, and she started reading labels. And this mini cycle kept going around and around. And a few months later, she eliminated foods that might have traces of carrot and stopped eating in restaurants or friends' houses. And this social isolation led to depression. When she ate something that she thought might contain carrot, her hypervigilant nervous system would remember her association between carrot and digestive distress, and she would get intense physical sensations. And this had two unfortunate consequences. Firstly, the experience reinforced her carrot symptom association. And secondly, she believed that her food sensitivities and digestive system health were worsening, which intensified her body mistrust. And in reality, she reacted to carrot, but it was primarily a conditioned reaction. And once again, I define conditioned food sensitivity as food reactions driven by inaccurate food symptom associations. So she was stuck in the CFAS, and this cycle continued, and her diet became more limited over the next few months. Janet's initial digestive distress was caused by the stomach flu and increased pressures at work, and would have resolved without further intervention. So her story is a great example of how temporary health concerns can create long-term food sensitivity if a client gets stuck in the C-fast. Jack's story is a typical example, but people can enter the cycle from any point and travel through it differently. And if you go to my website, I do have a video with 7 different examples, just quick little examples of different ways to enter. I want to spend a few minutes now talking about avoidant restrictive food intake disorder, or abbreviated as ARFID. It's an eating disorder in the DSM-5 that is often used to diagnose food restrictions that are motivated by something other than weight and shape concerns. There are 3 categories. The first is sensory. So the patient, typically children, is bothered by certain and is distressed by how some type of sensory aspects, such as texture, which is probably the most common, and the client may be in distress by how that food feels in their mouth. Smell and color can also present sensory challenges. The second is appetite. The patient has a poor appetite, maybe they're not interested in food, or they might not have enough energy to prepare meals, and this would be very common in depression and elderly people. And finally, aversive avoidance is driven by fear of something unpleasant happening, such as choking or vomiting. Within this category are patients who are concerned that food will exacerbate their disease or symptoms. Identifying and helping this patient population has received a lot of interest in the last few years. However, I wanted to point out that this group is different than other eating disorders and ARFID diagnoses. For example, diet can exacerbate disease and symptoms, so the fear is based on reality. In other words, food restrictions often involve psychological and biological in origin mechanisms. However, as we discussed, fear can intensify and generalize to other foods when clients are caught in the C-fast cycle. So food sensitivity perception is greater than reality. With other eating disorders and ARFID diagnoses, fear is typically not based on reality, and the restrictions are primarily psychologically driven. So for these reasons, I feel that conditioned food avoidance is a better term than ARFID to describe this group of patients. Now let's shift into talking about screening. So we need to identify these clients. Why would you screen? This allows clinicians to provide much needed support. So this fear and restriction often go unnoticed. Health professionals rarely ask clients about their relationship with food, and clients don't often recognize it as fear. They may attribute their worsening sensitivities to getting sicker. So they may stay stuck in the C-fast cycle with their hypervigilance, sensitivities, and health worsening over the years. By identifying clients, you can interrupt this cycle and make a substantial difference in your client's health journey. And it allows you to modify your interventions. Elimination diets are contraindicated for clients with severely restricted diets. Further restriction will be detrimental, and information on potentially problematic foods, which is what elimination diet teaching is based on, may exacerbate their fear. If the client is stuck in the C-fast cycle, but you and the client feel an elimination diet is the best course of action, it's important to take extra precautions. And I'm currently developing a course for health professionals on teaching elimination diets with positive language, and a video for clients that clients can watch before they start an elimination diet with tips to prevent worsening food and symptom hypervigilance. So then, how do we screen? Well, if we look at screening tools, the NIAS, or the 9-item avoidant restrictive food intake disorder screen, is the most common screen that has been used in research. But as we talked about, ARFID is a really wide diagnostic net, and recent studies have shown that the NIAS overdiagnoses and may pathologize necessary restrictions. If you are looking for a screening tool, I would suggest the Fear of Food questionnaire. It was developed and validated by Melissa Hunt and Hannah Zickergraf at the University of Pennsylvania. And I've included a link to the validation study in your references, and you can email me to get a copy of the questionnaire. It's not online for download, but if you're interested, please just email me. However, screening tools are time-consuming and aren't often used in practice. Open-ended questions are more time efficient, and I'm sure there are many things you need to assess for beside food fear, such as restriction driven by weight and shape concerns, food insecurity, difficulty with meal prep, etc. So here are a couple of questions that can help identify clients struggling in any of these areas. An example type question could be, is grocery shopping, meal preparation, or eating out stressful? Or does anything interfere with your ability to eat how you would like to? As you know, it's important to develop rapport before asking open-ended questions. Most clients are uncomfortable sharing until they trust the health professional. Typically, digestive health clients will answer yes to these questions, but that doesn't mean that they're trapped by food fear. Restriction and mealtime stress are expected when eating is painful, as it is for many clients. And the challenge is differentiating between this and excess fear-based restriction. So my top 4 red flags are when clients talk about safe foods. The word safe is common language in online support groups that encourage restriction. The second is restriction lists. Clients may say that they can't eat certain foods because that food is on a restriction list. For example, I can't eat tomatoes because they're high in histamine. As I'm sure you know, the internet is overrun by anecdotal lists such as low histamine, oxalates, salicylates, specific carbohydrate, GAPs, etc. Internet research, especially online support groups discussing food and symptom, really breeds fear. And finally, as we discussed, clients stuck in the CFAS typically have worsening avoidance and sensitivities over time. So when you notice these red flags, mentioning the CFAS cycle to your client would be worthwhile. Helping clients recognize a psychological role in their restrictions is a very delicate topic. Unfortunately, our society has this concept that medical suffering and distress are not real unless there is a definitive test and specific diagnosis. When there isn't, symptoms are often dismissed as stress or exaggeration. Understandably, clients may be defensive about the suggestion that their sensitivities and suffering might be psychologically influenced. So how do you bring it up? First and foremost, let your clients know that you believe them. This is essential. Their symptoms are real, regardless of the underlying mechanism. Hopefully, your initial screening questions lead to further discussion. And here is an example of a client conversation. So, you can read them on screen here, but I'll read them out for you. Is grocery shopping, meal preparation, or eating out stressful? I only have 10 safe foods, so I can't eat out. I have to make one meal for my family and another for myself. It's a lot of work. How long have you been limiting your diet? The last couple of years. That must be difficult. How did the restrictions start? I was in a lot of pain, and then I was diagnosed with Crohn's disease. My doctor told me to follow this specific carbohydrate diet, so I avoid all grains, additives, and sugar. I felt better for a few months, but started reacting to other foods. And I think it was histamine reactions, so I started a low histamine diet. Have you tried expanding your diet? When I cheat, I'm in terrible pain for the next few days, so I stick with it really carefully. I admire your dedication. Many of my clients have had similar experiences where they start a restrictive diet, but then suspect additional food triggers, which leads to more restrictions, and it just becomes a vicious cycle. It certainly feels like a vicious cycle. So here's the conditioned food avoidance and sensitivity trap. The dietitian very briefly explains it. Does this cycle resonate with your experience? Some parts of it do. Conditioned food avoidance and sensitivity might contribute to your reactions, and I'll email you a link with more information, and we can discuss it at your next appointment. So some of the keys is that question is key. Does the cycle resonate with your experience? If the client is stuck but doesn't recognize it, further discussion about the cycle probably won't be helpful and will compromise rapport with the client. Along the same lines, it is the client's responsibility to decide if the CFAS is relevant for them, not the professionals. People often contact me and ask if Rebuild Food Tolerance will help them, and I always direct them to modules 1 and 2, which are open to the public, and ask them to make the decision for themselves. And finally, it's important to introduce the CFAS as potentially contributing to symptoms, not as a definitive sole cause. So let's shift to interventions for clients who would like support. When I started working in this area, I developed diet expansion plans in the client's first appointment. And unfortunately, their reintroductions were often very difficult because they were still stuck in hypervigilance. So over time, I realized that the first step was fostering food and body trust. And I have some suggestions on my website, which there we go. So I hope that you can see that. This again is Rebuild Food Tolerance. This is open. You can go there on your own. I'm just going to close that. And I do realize now I am out of time, and it seems like there is a lot of questions. So I just want to show you that these tips you can read on your own as well as I can read them out to you. So they're divided into two, like basically I see food reintroduction as a step 1, step 2 process. The first step is fostering body and food trust. And that can take weeks, even a few months, depending on the client. And then going into food reintroduction. So I have tips on both of those that you can read at your leisure. And I would like to now close my presentation so we have time for our questions. So I will stop sharing.
Thank you so much, Wendy. I'm just going to bring Joe in as well. We're all virtually here together. Thank you both for a very thorough presentation. And one thing I love the most with the sort of content that you've covered is that it's obviously very practical for clinicians, but very easily communicable through to their clients. It's something they don't have to sort of reshift and restructure. It's very easy to pass on this sort of framework straight through to clients and patients. We've had some great discussion on the line. I'm just going to start running through. Not a question, but just a shout out, Joanna, as you were presenting a message from Kim that it's an FIT test at 50 in Ontario, Canada, not FOB. So there you go. We're operating all across the world here. First question is from Emily. In what situations do you send your patient back to the doctor to check for fecal loading? I think that question was for you, Joanna, but Wendy, if you'd like to jump in, you're welcome to.
So when am I sending people back to check for fecal loading? I guess, so the sorts of things, if people are coming in obviously complaining of bloating and feeling heavy and full, and they might be feeling distended, I will generally start digging into more questions about their bowel movements. How often are they opening their bowels? Are they feeling incomplete? Things like that. And if they're finding that they're feeling like they're not emptying properly, or they still need to go, but there's nothing coming, then fecal loading is something that I will always consider in that situation. It's also something that I consider if they've got a history of constipation and then they've suddenly developed some diarrhea, so sort of urgent sudden diarrhea. That might be an indication that there's some overflow diarrhea going on. So I would always be considering it then. When I'm going through their diet and they're eating like a fairly high fiber diet, but their bowel movements are not that big, or they're not sort of, if they're eating oats for breakfast and they're having seeds and nuts and whole grains and lots of fruits and veggies, but not doing like really big bowel movements, then I'm thinking, well, where is all that fiber going? Is it sort of still sitting in there? I'm kind of feeling like I'm almost at the point now where it's something that if somebody is complaining of bloating, it's something I will exclude before I start doing anything else. And I'll try and get those sort of more regular bowel movements going before I start doing other things. I do find in a decent amount of people, once we get their bowel movements going properly, a lot of them, the other symptoms resolve and they don't need sort of more intervention than that anyway.
Very sound advice. Thank you. There's been a bit of back and forth conversation. I might ask for both of your opinion as well, just on how much time you spend in your consults doing the patient or client education on CFAST or on just this condition food avoidance, compared to just sending them off with resources to watch, read in their own time. Just some commentary on that if you have a strong opinion.
A lot.
Yeah.
You, Wendy?
Why don't you go and I'll follow up.
Yeah, I probably spend more time on education than I do on interventions. I generally sort of spend a lot of time explaining and doing that education side. And then at the end of that, I say to the patient, look, you've got these sort of 2 or 3 options. Which path do you want to go down?
Yeah, and I tend to do more allowing the client to do as much as they can, learning on their own, picking out those key points, and then coming back to me. Because what I found is before I had online resources, I was actually spending about 12 hours. I'm private practice, about 12 hours with a client. It was like there's maybe like 20 little sort of nuggets. Those nuggets, you say something to somebody and they go, yeah, that changes my perspective. Let's say there's 20 of those, and if you don't, you've just met this client, you have some feel for them, some rapport, you almost have to go through it all, right, to find those nuggets for them. What I like to do then is allow them to do some reading on their own to find what really resonates with them, bring that back to me, and now we'll talk about that a little bit further.
Very sage advice. Thank you both. And it's one that sometimes very difficult to get the right balance. Like, you're managing your time, you're managing their time. So appreciate your expertise there. There's another question around the patient support group. So Wendy, you were talking about like a Facebook group and how that can sometimes feed the CFAST cycle. Again, how do you balance a client wanting to sort of have a shared experience with other people compared to perhaps falling into those Facebook groups, which can, again, cause that cycle?
Yeah, that's a great question, because a lot of times clients, no one else in their life understands what they're going through. And so online they can find other people. So I think if that person can participate in that group, but understand that a lot of the voices are very harsh about food, they can then learn to be more critical about what they're hearing. So still get the benefit of it, yet let go of the challenges of it.
Mm.
And ideally, what would be good is if we had moderated groups. I mean, there isn't the manpower for it, right? But if there was a place for people to share, where there's somebody there, like checking all of the comments and sort of modifying it, that would be ideal. But it's not realistic for that.
Yeah.
But if somebody's looking for something, you just have, hours in your day with nothing to do, that would be great.
Yeah. I often talk to people a little bit about how some research can be beneficial, but too much research, it's hard to find that balance with research, and just sort of discuss with that sort of more balanced approach, and how the more they research, the more they're going to amplify, whereas less research is going to reduce the focus. It's also, I've started a Facebook group myself for that reason.
Yeah.
Because I had so many of my patients were sort of joining these groups that were like way over restrictive and a lot of fear mongering. So I started my own group initially for my patients to come in, where we could sort of have something more balanced. It's probably, it is like Wendy said, it's extremely time consuming. I've got some other great admins that help me with it, but I hope to have a space where there's a bit of balance between being less restrictive, and I make sure that I'm bringing in a balanced approach when those discussions start happening. Those are the sorts of things that I will intervene and give an opinion on as well. Mm-hmm. It's not perfect, but I think it's a bit more balanced than some of the other groups that are out there. And I know that if my patients are getting that, I know that they're getting at least something balanced from this Facebook research.
Yeah, what a fabulous tool. And I know between your Facebook group, Jo, and Wendy, your resources and your programs online, we're trying to build that well-balanced view of how patients can work through this. Yes. We have another question from Joey here. How do you find working through the psychological elements? So some examples, working through emotional intelligence, processing, communication, versus stuffing it in their gut, as many patients with IBS can do. So do you find it helpful to let a client vent and go through that together? Any specific educational tools to help with their emotional vocab? Or I might add to this question as well, is there ever a time where you would bring in a psychologist or bring someone in to provide more psychological support? Again, Wendy, I might go to you first.
Yeah, for sure. So I think that we need to understand what our role is as dietitians. So if say someone, and I'm going to step back from food sensitivity because it's easier to explain it in how it was explained to me in mindful, like with mindful eating and binge eating disorder. So say in binge eating disorder, as dietitians, we can help someone identify disordered thoughts, help them replace those disordered thoughts, but we can't go into why do you have those disordered thoughts. So at that point, that's when we refer out to a psychologist. So I would, certainly as dietitians, we can help with strategies to reduce anxiety, but can't go into the whys of it. So yeah, I hope that answers.
When I'm seeing people, the first time I see people, I allocate a good amount of time to just let them tell me their story. I think that in the IBS space, a lot of people haven't had the chance for a provider to sit there and just listen to their story. And I think listening to them and validating their experience goes a long way in building that trust initially. Like Wendy says, when they're starting to sort of display sort of more disordered thought patterns and things, I have a really amazing psychologist that I work with who specializes in food. So I'll often send people off to there, and they come back from seeing her magically wandered over, and we carry on with what we were doing.
Yeah.
So, but yeah, I really value her input. She makes a big difference.
And that definitely speaks to the multimodal approach that we keep talking about as well, right? It's great to have a good care team. Excellent. I'm just having a final scroll through, not a question, but a comment from Ian. Dr. Google is my friend, drives a lot of business, and that can be unfortunately very true for a lot of patients that end up getting stuck in that cycle. If there's any, I'm just having a quick scan through. If there's any other questions, pop them in the Q&A box or in the comment space as well. I'm having a scroll through both. And there's some questions, I guess, on the resources that we've spoken through. So after today, we'll send through this recording, which will obviously have the slides on the screen share, as well as a fact sheet, which is a great summary of all of the content that we've spoken through today. Both Joanna and Wendy have contributed to that. And any other resources. I know there's been some comments, Wendy, asking for your website so that clinicians can have that on hand for themselves and for their clients. I believe, just some lovely comments coming through as well. Very helpful to hear your perspectives. And thank you both. This is, I know, what your passion space and something that you both spend a lot of time working in. So I think we might call this session to a close. Again, a huge thanks to our speakers. We will follow up shortly, again, with all of the resources, and hope to see you all at the next webinar presentation. Thank you, everyone.
Yeah, and thank you to Mindset Health for putting this together for us. Really appreciate it.
Very much.
Great team. Thank you, everyone.